Welcome to the Deep Dive. Today we're tackling a really important topic in medicine, sickle-cell anemia. Now, diving into medical details can sometimes feel, well, a bit dense, can't it?
It definitely can.
But our goal here is to pull out the crucial information, the stuff that'll really stick with you in a way that's clear, memorable, and hopefully even a little bit interesting. Think of this as your express route to understanding.
Exactly. We've looked at a lot of information, sort of distilled it down to give you a good, solid overview without getting too bogged down. Our aim is that by the end of this, you'll have a strong grasp of sickle cell anemia, from what it is right through to potential complications, plus some handy ways to remember the key points.
Okay, sounds good. Let's get right to it then. What exactly is sickle cell anemia in simple terms?
Well, okay, at its heart, sickle cell anemia is something you inherit. It happens because the body makes a faulty version of hemoglobin, that's the protein in red blood cells carrying oxygen. We call this abnormal hemoglobin HbS. Now, this HbS makes the normally round and flexible red blood cells become stiff and shaped like, well, sickles or crescent moons.
Hence the name.
Precisely. These misshapen cells can then get stuck in blood vessels, causing blockages. And that leads to pain and can, unfortunately, damage organs over time. The root cause of all this is a specific mutation in a gene called HBB.
Okay, and what about sickle cell trait? We hear that term used quite a lot as well. Is that the same thing?
Good question. No, it's a key distinction. Sickle cell trait happens when someone inherits just one copy of that mutated HBB gene. These individuals are heterozygotes. They usually have about 60% normal hemoglobin HbA and maybe around 40% of the sickle type HbS.
So a mix.
Exactly, a mix. And here's a fascinating point. Having the trait actually offers some protection against malaria. Yeah, specifically Plasmodium falciparum. That's why the trait is more common in regions like sub-Saharan Africa.
Yeah.
Generally, people with the trait don't have symptoms, but sometimes there can be issues like hematuria, blood in the urine, or maybe some kidney problems. Simple things like staying well hydrated and avoiding low oxygen situations, hypoxia, can help prevent these.
Got it. So sickle cell disease is the broader term then, and sickle cell anemia is one specific type under that umbrella.
Precisely. Sickle cell disease is the overall category for inherited conditions affecting hemoglobin. Sickle cell anemia, specifically when someone inherits two copies of the mutated gene, we call that HbSS, is the most common and often the most severe form. You see it particularly in people of Afro-Caribbean heritage.
Okay.
So just to recap, sickle cell anemia itself comes down to that beta-globin gene mutation, and its higher prevalence in places like sub-Saharan Africa is linked to that malaria resistance in carriers. Nature's trade-off, sort of.
Right. A complex picture already, so we know what it is. Now let's talk about how it actually happens, the etiology.
Okay, the etiology. It really boils down to a chain reaction, starting with that HBB gene mutation. This mutation changes the blueprint, if you like, for hemoglobin. So instead of making normal hemoglobin A, the body starts producing hemoglobin S, or HbS.
And HbS is the problem molecule.
That's the one. It makes the normally bendy red blood cells become stiff and sickle-shaped, especially when oxygen levels dip. And remember, it's an autosomal recessive disorder.
Meaning?
Meaning you need to inherit the mutated gene from both parents to get the full condition, sickle cell anemia. If you inherit just one mutated gene from one parent, you get the milder sickle cell trait we just talked about.
Okay, that clarifies the inheritance.
Yeah.
So who is most at risk then? What are the main risk factors we should know?
Well, the biggest risk factor is definitely family history. If sickle cell trait or disease runs in the family, the risk goes up. It's also much more common in people whose ancestors come from specific parts of the world, of Africa, the Mediterranean, the Middle East, or India. And the key, as we just said, is that inheritance pattern. Both parents must carry at least one copy of the sickle cell gene. Consanguineous marriages, where parents are closely related, like cousins, also increase the risk because they're more likely to share the same mutated gene.
Makes sense.
And finally, just living in or having ancestry from geographic regions where the gene is common, often because of that past malaria protection, means a higher population risk.
Okay. Now let's get into the nitty-gritty of what's actually happening inside the body, the pathophysiology. How does that faulty hemoglobin cause so many problems?
Right, the pathophysiology.
Right.
It all kicks off with that abnormal hemoglobin S inside the red blood cells. When oxygen levels drop, say, during exercise, illness, or at high altitude, these HbS molecules start to link together. They form long, rigid chains or polymers.
They polymerize.
Exactly. And this polymerization forces the red blood cell to change shape, becomes rigid, distorted into that characteristic sickle shape. Now, here's the problem. These sickle cells aren't flexible like normal disc-shaped red blood cells.
So they get stuck.
Precisely. They tend to get stuck in the tiny blood vessels, the capillaries, blocking blood flow. This is called vaso-occlusion. This blockage means tissues downstream don't get enough oxygen, leading to tissue damage and, importantly, severe pain, the hallmark of a sickle cell crisis.
Ouch.
Yeah. Plus, these sickle cells are fragile. They don't live as long as normal red blood cells, maybe 10, 20 days instead of 120. This rapid destruction leads to chronic anemia because the body can't replace them fast enough.
Okay, so anemia and blockages.
And there's more. The breakdown of these cells releases free hemoglobin into the bloodstream, which can actually cause oxidative damage and inflammation. So it's this whole cascade, really. The sickling, the blockages, the short lifespan, the anemia, the free hemoglobin, all stemming from that single gene mutation and contributing to pain and organ damage.
It really is like a domino effect at the cellular level. Now, if someone comes in with symptoms like anemia or pain, what else might doctors consider? What's the differential diagnosis?
That's a really important question in clinical practice. When someone presents with anemia, you have to think broader initially. Could it be other types of anemia? Maybe other inherited hemoglobin problems like thalassemia, or perhaps autoimmune hemolytic anemia where the body attacks its own red cells, or even hereditary serocytosis, another condition affecting red cell shape.
So, other red cell issues.
Yes, and specifically for someone known to have sickle cell disease who presents with acute pain, it's crucial to differentiate. Is this a typical sickle cell pain crisis, a vaso-occlusive crisis, or could there be another cause for the pain, an infection maybe, or something else entirely that needs a different investigation or treatment approach?
Right, you can't just assume it's always a sickle crisis.
Exactly. You have to keep an open mind.
Let's zoom out again and look at the bigger picture, the epidemiology. How common is this, particularly here in the UK?
Okay, epidemiology in the UK. Sickle cell anemia predominantly affects individuals whose heritage traces back to Africa, the Caribbean, the Middle East, and South Asia. It's estimated that around 15,000 people in the UK currently live with sickle cell disease.
15,000? That's quite significant.
It is, and sickle cell anemia, the HbSS form, is the most common and generally the most severe type within that group. The prevalence, though, it really varies depending on ethnic background.
Yeah.
It's much higher in people of African and Caribbean origin. For instance, the carrier frequency for the sickle cell trait can be as high as 1 in 4 in people of West African descent and maybe 1 in 10 in those of Afro-Caribbean descent.
Wow, 1 in 4 is very high.
It is. And again, that links back to the protection against Plasmodium falciparum malaria that the trait provides. That selective advantage historically led to higher gene frequency in those populations.
Fascinating link. Now, what does sickle cell anemia actually look like in a person? What are the common clinical features? How does it present?
Well, the presentation can be really variable, but there are some typical features. Almost everyone with sickle cell anemia will have chronic anemia. This often leads to ongoing tiredness, fatigue, maybe shortness of breath on exertion.
Okay, the anemia aspect.
Then there are the sickle cell crises. These are episodes of severe pain, often in the bones, chest, or abdomen, that can come on quite suddenly. They're a major feature. Also because the spleen often becomes damaged early on, what we call functional hyposplenism, or even autosplenectomy.
The spleen essentially stops working.
Right, and the spleen is crucial for fighting certain types of bacteria. So there's an increased susceptibility to infections, especially in children. This can be very serious.
Infections are a big risk then.
Definitely.
Yeah.
You might also see delayed growth and development in younger patients. And over the longer term, the repeated blockages and chronic lack of oxygen can damage various organs of the lungs, leading to things like pulmonary hypertension or acute chest syndrome, the spleen, as we mentioned, the kidneys, the brain causing stroke risk, the bones leading to a vascular necrosis. The list is quite long.
So pain, anemia, infections, organ damage.
And other potential complications like leg ulcers, gallstones due to the rapid red cell breakdown, and even priapism. It's really important to stress, though, that the severity and frequency of these symptoms can vary hugely from person to person. It depends on their specific genotype, age, environmental factors, and the care they receive.
And what about the early warning signs? When do symptoms typically first appear?
In individuals with the homozygous HbSS form sickle-cell anemia, symptoms usually start showing up around 4 to 6 months of age.
Why then specifically?
That's the point when the levels of fetal hemoglobin, HbF, naturally decline. HbF is protective. It doesn't sickle as readily. As it gets replaced by the adult, abnormal HbSS, the problems begin. Early signs in babies can include jaundice, that yellowish tinge to the skin and eyes, ongoing tiredness or lethargy, maybe not feeding well, slower growth, and dactylitis.
Dactylitis.
Yes, that is a painful swelling of the hands and feet, sometimes called hand-foot syndrome. It's often one of the very first signs. They also become prone to those serious infections we talked about.
And in adults, are the common issues different?
The underlying issues are the same, but the cumulative damage means adults often present with the consequences. Reasons for hospital admission in adults frequently include severe bone pain crises, lung complications like pulmonary hypertension or chronic lung disease, worsening anemia, a vascular necrosis causing joint pain, particularly in the hips or shoulders, also higher rates of infection, persistent leg ulcers, heart problems like cardiomegaly or heart failure, neurological events like stroke or cognitive issues, pigmented gallstones, chronic liver enlargement, kidney disease, eye problems or retinopathies that can affect vision, that non-functional spleen, autosplenectomy, and bone infections like osteomyelitis, often caused by unusual organisms like salmonella.
It sounds like it can really impact almost every system in the body over time.
It truly can. That's why comprehensive lifelong care is so crucial.
Okay, that gives us a very clear picture of the clinical side. Now, how do doctors actually confirm the diagnosis? What investigations are key?
Diagnosis involves several steps. Usually, a complete blood count, or CBC, is done first. That looks at hemoglobin levels, red cell size, white cells, platelets. It'll typically show anemia.
But that's not specific.
No, anemia has many causes. The gold standard test to actually identify the abnormal hemoglobin S is hemoglobin electrophoresis, or high-performance liquid chromatography, HPLC. These methods separate out the different types of hemoglobin in the blood sample, allowing us to see the presence and amount of HbS and the absence of normal HbA in sickle cell anemia.
Right, that confirms the type of hemoglobin.
Exactly. Genetic testing can also be done, especially in prenatal diagnosis or for confirming specific genotypes, looking for those mutations in the HBB gene. And then, depending on the clinical picture and potential complications, imaging studies like ultrasound or MRI might be used to evaluate organ function, checking the spleen, liver, kidneys, brain, bones, etc.
You mentioned prenatal diagnosis. What about screening newborns? Is that standard?
Oh yes, newborn screening is absolutely vital and standard practice here in the UK. Babies are usually screened via heel prick blood test between 5 and 9 days of life. That sample is tested using hemoglobin electrophoresis, or HPLC.
And that picks up sickle cell anemia early.
Yes, it can reliably identify sickle cell anemia, HbSS, sickle cell trait, HbAS, and other significant hemoglobin disorders like HbSC disease or beta thalassemia. This early diagnosis is critical because it allows preventative treatments, like penicillin prophylaxis to prevent serious infections, to be started immediately, often before the baby even shows any symptoms. It saves lives.
That makes sense. What about diagnosing older children or adults who weren't screened?
In older individuals, the diagnosis might be suspected based on their family history, their ethnic background, and of course their symptoms like those painful crises or chronic anemia. Looking at a peripheral blood film under the microscope is also very helpful. You can often directly see the characteristic sickle-shaped red blood cells, target cells, and sometimes signs of poor spleen function like hollow-jolly bodies.
Are there other specific blood tests used?
Yes, a few others are useful. The FBC-N film, as mentioned, will show anemia, HB, typically 6 to 8 GDL, a high reticulocyte count, often 10–20%, indicating the bone marrow is trying hard to compensate, and those characteristic cell shapes. There's also a rapid screening test called the sickle solubility test. It uses a reducing solution. If HbS is present, it becomes insoluble and makes the solution cloudy or turbid. It's quick, but not definitive.
So electrophoresis or HPLC is still needed?
Absolutely. That confirms the diagnosis. In sickle cell anemia, HbSS, you'll typically see no HbA, mostly HbS, maybe 80–95%, and a variable amount of HbF, fetal hemoglobin, maybe 2–20%. For sickle cell trait, HbAS, the sickling test would be positive, but electrophoresis shows both HbA, usually more, and HbS. We also routinely check baseline kidney function, urea and electrolytes, liver function tests, LFTs, and lung function tests, and repeat these periodically for monitoring.
And other tests depending on the situation?
Yes, if complications are suspected, say, infection, then infection screens are done. An abdominal ultrasound might check for gallstones or spleen size. A head CT or MRI if a stroke or bleed is suspected. It's tailored to the individual.
You've really emphasized the importance of newborn screening.
It cannot be overstated. Identifying babies early allows for penicillin prophylaxis, crucial vaccinations, and parental education, all of which dramatically reduce the risk of potentially fatal sepsis in infancy. That simple heel prick is incredibly powerful.
What about testing before pregnancy or during?
Yes, preconceptual testing and counseling are strongly recommended for individuals in at-risk populations. Screening policies during pregnancy exist across the UK, usually offered based on ethnicity or family history questionnaires. Newborn screening is universal. Sometimes fathers are also offered testing if the mother is identified as a carrier.
And before surgery.
Preoperative screening is important for people from high-prevalence ethnic groups, especially before major surgery involving general anesthesia, to identify risks and plan accordingly. In emergencies, that sickle solubility test might give a quick clue, but it always needs confirmation with definitive analysis like electrophoresis or HPLC.
Is it possible to diagnose before birth?
Yes, prenatal diagnosis is an option for couples known to be at high risk of having a child with sickle cell disease. It involves procedures like amniocentesis or chorionic villus sampling, CVS, to get fetal cells for genetic testing. Fetal blood sampling is another rarer option. These are always preceded by detailed genetic counseling to discuss the risks, benefits, and implications.
Okay. Now, thinking about managing the condition day to day or during crises, what are the key signs that would tell someone, okay, I need to get to the hospital urgently?
That's critical knowledge for patients and families. There are definite red flags. Severe pain that isn't getting better with their usual home management plan, including simple analgesia or low-dose opioids.
Uncontrolled pain.
Yes. Also, significant dehydration, maybe from vomiting or diarrhea, as that can trigger or worsen a crisis. Signs of severe infection or sepsis are crucial. A high fever, like over 38.5 degrees C, or 38 degrees C is under 2, or sometimes a very low temperature, below 36 degrees C, looking very unwell, maybe confused or drowsy.
Infection signs, got it.
Any symptoms suggesting acute chest syndrome, that's a medical emergency. Things like chest pain, shortness of breath, rapid breathing, coughing, fever, low oxygen levels. New neurological symptoms are also an emergency. Sudden weakness, numbness, difficulty speaking, visual changes, severe headache, seizure. These could indicate a stroke.
Neurological changes, immediate action.
Absolutely. Also an acute sudden drop in hemoglobin levels, making them much paler or more tired than usual. Sudden enlargement of the spleen or liver, especially in young children, this can be splenic sequestration, another emergency. A marked increase in jaundice, significant visible blood in the urine, hematuria, and priapism, a persistent painful erection lasting more than 2 hours, or a pattern of worsening recurrent episodes. All of these need urgent hospital assessments.
That's a really important list. Okay, so we've covered diagnosis and red flags. Let's move on to the overall management strategies. How is sickle cell anemia managed long-term?
Management is multifaceted and lifelong. It really focuses on preventing complications, managing symptoms when they do arise, and supporting overall health and quality of life. Regular monitoring by a specialized healthcare team, hematologists, specialist nurses, pediatricians, if relevant, is central. They monitor growth, development, organ function, and screen for potential complications.
So regular checkups are key.
Essential. Preventative measures are also crucial. This includes ensuring all routine childhood vaccinations are given, plus additional ones like the pneumococcal vaccine, repeated every 5 years, and annual flu jabs. Daily antibiotics, usually penicillin V, are given prophylactically to children, typically up to at least age 5, to prevent serious pneumococcal infections.
Right, preventing infections is high priority.
Absolutely. Then there's pain management. For acute, painful crises, the mainstays are strong pain relief, analgesics, often opioids, ensuring good hydration, sometimes intravenously, and sometimes oxygen therapy if levels are low. Equally important is educating patients on avoiding potential triggers for crises, things like dehydration, getting cold or overly hot, infections, excessive stress, or strenuous exercise without proper hydration.
What about specific medications for sickle cell itself? We often hear about hydroxyurea.
Yes, hydroxyurea, also called hydroxycarbamide, is a very important medication for many patients, usually those with more frequent or severe problems. It works primarily by increasing the production of fetal hemoglobin, HbF. Remember, HbF doesn't sickle as easily.
Right, the protective baby hemoglobin.
Exactly. So more HbF means fewer sickle cells forming, which leads to fewer painful crises, a lower risk of acute chest syndrome, and often less need for blood transfusions. It requires careful monitoring, though.
And blood transfusions themselves, when are they used?
Blood transfusions are a vital tool. They can be given as simple top-up transfusions to treat severe anemia or improve oxygen delivery before surgery, for example. Or, more commonly in severe situations, as exchange transfusions. This is where some of the patient's blood containing HbS is removed and replaced with donor blood containing normal HbA.
When would an exchange transfusion be done?
For life-threatening complications like acute stroke, severe acute chest syndrome, or sometimes prophylactically in high-risk situations, like preventing stroke recurrence or during high-risk pregnancies. The aim is to rapidly reduce the percentage of HbS.
Are there newer therapies coming through?
Yes, things are moving forward. Crises is a monoclonal antibody medication. It works differently from hydroxyurea. It targets a molecule called p-selectin involved in cell adhesion. By inhibiting this, it helps reduce the frequency of vaso-occlusive crises. NICE has recommended it in the UK for some patients over 16 who continue to have frequent crises despite hydroxyurea under specific access arrangements.
That sounds promising. What about cures, like transplants?
Bone marrow, or hematopoietic stem cell transplantation, is currently the only potential cure for sickle cell anemia. It involves replacing the patient's bone marrow with healthy marrow, usually from a matched sibling donor. However, it's a complex procedure with significant risks, like graft versus host disease and rejection, and finding a suitable donor can be difficult. So it's typically reserved for severe cases, often in children who have a matched sibling.
So, not an option for everyone.
Not currently, no. Psychological support is also a really important, though sometimes overlooked, part of management. Living with a chronic, painful, and unpredictable condition takes a toll.
I can imagine.
Access to counseling, support groups, and therapies like cognitive behavioral therapy, CBT, can make a big difference in coping strategies, managing pain perception, and dealing with anxiety or depression.
That holistic approach seems vital.
It is. And we also focus on preventing specific complications, regular eye checks for retinopathy, kidney function monitoring, stroke prevention screening in children using transcranial Doppler ultrasound.
You mentioned pregnancy earlier that needs special care.
Yes, pregnancy in women with sickle cell disease is high risk and requires joint care from hematologists and obstetricians. They need close monitoring and may need specific treatments like aspirin or low molecular weight heparin to reduce clot risk, plus potentially more frequent transfusions.
What about things like surgery or travel?
General anesthesia carries increased risks, so careful preoperative assessment and planning with the hematology and anesthetic teams were essential. Travel needs planning too, especially air travel or travel to high altitudes or regions with malaria. Key advice includes maintaining excellent hydration, getting appropriate vaccinations and anti-malarial prophylaxis if needed, and knowing how to access care if a crisis occurs abroad.
And the future, gene therapy.
Gene therapy is a very exciting area of active research. The idea is to correct the faulty HBB gene or add a functional gene to the patient's own stem cells. Early results from clinical trials are promising, with some patients achieving significantly reduced disease severity or even becoming transfusion independent. But it's still complex, expensive, and not yet widely available standard practice. It's definitely one to watch, though.
And those national hemoglobinopathy cards.
Yes, everyone diagnosed with a significant hemoglobinopathy in the UK should be issued one. It contains key information about their specific diagnosis and baseline health, which is invaluable in emergencies if they present to a hospital where they're not known.
It sounds like early intervention is really the name of the game.
Absolutely. Early diagnosis through newborn screening, starting penicillin prophylaxis promptly, ensuring vaccinations are up to date, screening for stroke risk with transcranial Doppler in children aged 2 to 16, and offering regular transfusions if abnormal. Using hydroxyurea effectively, considering stem cell transplant for eligible severe cases, all these interventions introduced over the last few decades have dramatically improved outcomes and life expectancy.
So continuous care at specialist centers is important.
Critically important. Regular reviews allow for monitoring of growth, development, organ function, early detection of complications, and adjustment of management plans. Patient education is also key, empowering individuals and families to understand their condition, avoid triggers, recognize warning signs, and manage pain effectively at home when possible.
You mentioned strict prevention screening. How is acute chest syndrome or priapism treated?
Acute chest syndrome requires prompt hospital admission. Treatment includes oxygen therapy, incentive spirometry, breathing exercises to keep the lungs clear, broad-spectrum antibiotics, as infection is often a trigger or coexists, pain relief, hydration, and often blood transfusion or exchange transfusion. For priapism, initial management involves hydration and pain relief. If the erection persists beyond a few hours, urological intervention is needed, typically involving aspiration of blood from the penis, sometimes followed by irrigation with medication like phenylephrine. Preventing recurrence is also important.
What about contraception? Any specific considerations?
Most methods are considered safe. Both hormonal methods, like the pill, implant, injection, and barrier methods, are generally fine. There's some suggestion that progestogen-only methods, particularly the depot injection, might even help reduce the frequency of painful crises in some women, but more research is needed there.
And managing those painful crises at home.
Mild to moderate crises can often be managed at home with rest, increased fluids, warmth, and regular doses of simple analgesics like paracetamol and ibuprofen, sometimes stepping up to codeine or tramadol under guidance from their specialist team or community support. Hydroxyurea plays a big role in reducing the frequency of these crises needing hospital admission.
It's a complex condition to manage.
Yeah.
What's the long-term outlook, the prognosis, for someone with sickle cell anemia today?
The prognosis has improved significantly over the past few decades, especially in high-income countries with access to comprehensive care. But it still varies quite a bit. It really depends on the severity of the disease in the individual, the specific genotype, the frequency and severity of complications they experience, their access to specialist care, and crucially, their adherence to treatments and preventative measures.
So life expectancy has improved.
Yes, dramatically compared to, say, 50 years ago. Medical advances, particularly in preventing childhood infections, managing complications, and treatments like hydroxyurea and transfusions, have made a huge difference. Median life expectancy in high-income countries is now estimated to be somewhere in the range of 40 to 60 years, maybe even longer for some, although it's still significantly reduced compared to the general population. In lower-income settings without the same resources, unfortunately, the outlook is often much poorer.
What are the main factors that still limit lifespan?
Even with good care, chronic organ damage can accumulate over time. Common causes of premature death in adults now often relate to complications like pulmonary hypertension, stroke, kidney failure, sepsis, or acute chest syndrome. In infancy and early childhood, infections remain a major risk, especially where preventative care isn't optimal. But it's important to remember the variability. Some people have relatively mild disease, while others face severe, frequent complications.
Finally, could you just summarize the main potential complications again? We've touched on many, but just to have a clear list.
Sure, it's quite a list, unfortunately reflecting how widespread the effects can be. Key complications include the vaso-occlusive painful crises, of course, chronic anemia and fatigue, increased susceptibility to serious infections, particularly encapsulated bacteria, due to spleen dysfunction, stroke, both overt strokes and silent strokes that can affect cognitive function, acute chest syndrome, a leading cause of death, pulmonary hypertension, chronic kidney disease, potentially leading to renal failure.
That's already a lot.
There's more. A vascular necrosis, especially the hip and shoulder joints, leg ulcers, which can be chronic and difficult to heal, gallstones, usually pigmented stones from increased bilirubin, priapism, eye complications like sickle-cell retinopathy, which can lead to vision loss, delayed growth in puberty, complications related to treatment like iron overload from multiple transfusions, and increased risks during pregnancy. Cardiac issues like an enlarged heart or heart failure can also occur. Learning difficulties are also recognized as a potential complication, possibly linked to anemia or silent brain infarcts.
Wow, it really underscores the need for comprehensive lifelong management.
Absolutely. These complications significantly impact health, quality of life, and lifespan, and they all require prompt recognition and appropriate medical attention. Understanding this range is crucial for anyone involved in the care of people with sickle cell disease.
So it's definitely a multifaceted condition requiring a really thorough understanding from genetics right through to long-term care.
Exactly. Getting a good grasp of sickle cell anemia, all its different facets, is just essential for providing the best possible care and support.
Well, this has been incredibly informative. If this deep dive has sparked your interest and you'd like to explore any of these areas further, we really do encourage you to check out reliable medical resources. Gaining this kind of foundational knowledge is such an important step in understanding complex conditions like this one. And of course, for more in-depth resources specifically geared towards medical exams and to test your understanding, do visit passthemsra.com.
That's right. And you can also find a wealth of free learning materials covering various topics over at freemsra.com.
Definitely worth checking out both of those sites.
You know, it's truly remarkable when you think about how far our understanding and treatment of genetic conditions like sickle cell anemia have come. And research is constantly ongoing. Gene therapy, newer medications. It really makes you optimistic about the possibilities the future holds for improving lives further.
A hopeful note to end on. Thanks for joining us on the deep dive.